to the Kent Lapp Podcast.
Dr. Dustin Howard, welcome, my man.
What's up? Thank you for having me.
Thanks for coming by. I'm excited.
Same here.
So the book you just pulled out of your back pocket. And I was like, well, save this for the podcast. Anatomy Trains.
Correct.
Why'd you bring the book? What's going on with this?
So this book, honestly, it has shaped a lot of what I've done in recent years on how I approach people, how I work with people, literally how I train people. So I'm a physical therapist and personal trainer. That's what I do. And it really does a great job of describing how intimately connected the body is with itself. So the body is comprised of muscle, bone, ligaments, tendons, nerves, fill in the blank, connective tissue, lots of other things, lots of organ systems. But one of the most neglected systems is actually the fascial system. And that's what this book talks about. It talks about myofascial lines and meridians. And I'll just pull one for you real quick.
And as you're doing that, what is that? What is a myofascial line or meridian?
Yeah, so I'll just roll off this one. This is called the spiral line. Basically, it is a line of muscle and fascia. So fascia, think of it like this. I always tell people, take a piece of chicken, like a chicken breast, right? Peel the skin back, and the little filmy layer, that's what you're dealing with. That's fascia right there, in essence, okay?
If you peel the skin back, so then you have that little
slimy layer in between.
Sure.
Kind of slicky.
Yep.
Now, there's two different types of fascia, though. You have one that's the dense fascia, that's the deep fascia, and it's very thick. It's very hard to change that. It takes 2,000 pounds of force to change that. So unless you're, put an alligator bite force on it, you're really not going to do much to that one.
On the human body?
Yes. Yeah.
Okay.
It takes a lot to deform that. But if you talk about the superficial layer of fascia, that's different, okay? So you have basically like the stacking of fascial layers, and it goes right up under the skin. So you got the skin layers, you have the dermis, epidermis, all that other fun stuff we all learned in anatomy. And then basically you go down below that, you have the fascial layers that sit right above the muscle. What's really cool is in muscle, we have this stuff called epimysium, perimysium, and endomysium. And what that is basically how the fascia starts to blend into the muscle, okay? And then what's really, really cool is that you go down to the tendon and you have the same thing, only at the tendon level. And then that blends into the bone, okay? So you have epiosteum, periosteum, endo, different layers, all this other stuff as well.
Layers of fascia, or that's underneath the fascia?
It's kind of how everything blends together.
I see, okay.
So it's not just like a hard, okay, we have a screw into the bone.
Yeah.
That ain't how it works.
Yes,
okay?
I see.
It's like a blending of tissue in, and then that's how everything's connected, okay? So it's the old model, like when you think about the skeleton, right? There's screws and stuff on the skeleton. It don't work like that. Okay? It does not work like that at all.
We'd all be beeping going through airport
going like
scanners.
this, like, all right, this is all I can do. Wait a minute, no, it can't go that way. No. But that's the truth. Like if you ever tried to range a skeleton's shoulder, it don't work very good.
Yeah, it's true. I mean, that is something I've thought of before, is just how the design behind the human body is. It's mind-blowing.
Yeah.
Because look at the fluidity of that movement.
Yeah.
You know what I mean? And the fact that you can go out, we were hiking in Arizona a few weeks ago, and the fact that we could go out and hike for miles and then come back and take a rest, eat a burger, and go out and hike again for miles. And you don't have to do an oil change. You don't have to inject lubricants into your hip. You know what I mean? Like the body just...
It's its own natural system.
It's so natural. It's amazing.
Yeah. So the fascial system itself is, I always tell people, it's one of the most highly innervated sensory systems in the entire body. It really is. So think of it this way. Like if you can move your skin around really easy, like there are certain parts of, say you have an injury, right? Let's just take scar tissue, for example. Everybody knows, if you get a surgery, you have scar tissue, right? You get a cut, boom. Now, all of a sudden, you have a scar, say you had an ACL tear, right? Prime example, a lot of people have had those. You'll have the little bore holes that they do, and they put the scope in, and they do the thing. Or if you had a Patella Tendonograph, then you have this linear scar that goes right on the front of your patella, like your kneecap, down to the bone down below that. Well, oftentimes what will happen is that scar will bear down. Okay, what's really interesting is oftentimes the scar gets neglected, and so it starts to bear down.
What do you mean bear down?
Like it gets caught. basically you develop these adhesions under the skin that sit on the underlying tissue. So like, if I'm talking about my knee right here, right? If we're talking about like a Patella Tendonograph, like for example, I'm throw my leg up on here. So you can see. But basically, if right here, if I have a scar there, they take a bony plug out of here, bony plug out of here, and now all of a sudden they use that as the graft. But they pull it out. What happens is anytime you cut the skin open, you're going to have scar tissue, always. The body it freaks us like, all right, we got to fix this. So let's just chunk a bunch of connective tissue and everything right there because we got to fill this void that's here now. Okay. So oftentimes what happens is you get a little bit of hypertrophic growth in there and it will bear down. Okay. It actually adheres down. And you can ask my friend Michael and Cassie about that. Okay. That they're very familiar with scar tissue. I'll leave it like that. Not that there's been any experience with me regarding that. No. Anyways, so in essence, what happens is that scar gets tied up and it won't move well. Well, what's interesting is because it's a highly sensory innervated system, sometimes you'll have referral patterns of pain that are really like nervy and real funny. The Patella Tendonograph is one in particular on athletes that have had ACLs and stuff like that. If you entrap the saphenous nerve right there, you can have this searing pain that goes.
I see.
It almost acts like sciatica, but it's not.
Okay.
It's a referral pattern.
Is the pain going down this fascia at that point?
It could. Possibly. Or it could be going down a dermatome.
I see.
Most likely it'll be going down like a fascial line or something like that. Another example is a lady that had a total hip. I saw her. She acted like she had sciatica. She was bent over, and she was having this excruciating pain in her buttock. And they would look at the MRI. They're like, you got a blown disc. You're about to have another surgery. You'd already have two. And I was like, something isn't right. And then I something that is in my gut. I really feel like it was God, like Holy Spirit was just saying, hey, take a look at this and ask this question. Because I heard she had a total hip. And I said, okay.
She'd already had a total hip replacement?
Yeah, she'd already had a total hip. Yep. And so I asked her, I said, what kind of total hip did you have? What approach? Was it the front? Was it the side? Where did it go? And she said it was on the front. And she happened to be bent over. So I'm going to stand up real quick. But basically she came in like this and she couldn't stand up. She was turned to one side like that. And that's how she was moving. She could not get out of that position. And so I said, well, if it's okay with you, I'm going to actually look at your scar. Has anybody looked at it? And she's like, no. Why would they look at my scar? Well, let's just see. And so we looked at the scar, which is right in like kind of where the hip flexor is on the leg. And sure enough,
like how long, just for reference, like just like
so the scar, I would say, a few
5-6 inches.
Yeah,
okay.
a few inches long.
Okay.
And anyway, so I went to check the scar. It was like me trying to move this table.
Oh, okay.
It wouldn't move. It was hard.
Oh, wow.
And so I took my, I have this, what's called IASTM tools, Instrument Assisted Soft Tissue Mobilization. That's what the acronym stands for. And I have a silicone attachment that I use for specifically scars. Excuse me. And so we put it on there, and then I started moving it, and the skin started finally moving. I broke it loose. You could feel it going under my tool.
No way.
Yeah. You could like totally feel it.
What's it breaking loose from?
So
the bone?
Fascial layers. So it goes back to the thing we're talking about. So because it creates those adhesions through the fascial layers and it bears it down on the whatever it is underlying. It could be muscle, could be bone, could be whatever.
I see.
It just depends on what's under it. And so for her, we broke that loose. And then as soon as we did that, she's like, oh, that feels better. I said, okay, we'll stand up. I did nothing to her back. Zero. Not one. Touched her back. She stood up and walked all over that clinic. Had zero pain.
She stood up straight?
Completely straight.
She came in a little bent over, and you released the scar from whatever it was attached to, and she could stand up straight and walk around.
Yep. Completely pain-free.
My gosh, that's crazy.
And that was one session.
Wow. But was it painful when you're breaking the scar loose? Did that hurt her? Or
actually, no.
There's not pain there.
It was uncomfortable and felt like a stretch kind of thing, but it wasn't really painful. And she was like, actually, it kind of feels good. It's kind of, I always tell people, you'll feel like a stretchy pain. That's what I tell people.
I see. Okay.
For the
Now,
most
does
part.
she have to keep working that scar,
Yes.
or else it will reattach? Or once it's free, it's free?
Depends, but I always tell people you want to work the scar, and probably for the next 6 to 8 months, you want to keep working it daily. And it doesn't take long.
Yes. Okay. I have a friend who ran straight into a stop sign or some kind of a metal sign at like 5:30 in the morning doing a workout. I don't know. This was a while ago. You got a, as you would expect, a scar, and whoever fixed it up just told him, like, just work it, work it. Just whenever you think about it, just kind of rub on it a little bit.
Yeah.
And so do you think that's why, like, trying to keep the scar free from attaching and just being this permanent kind of block that's just stuck on the head, is that why you would work that?
So the skin takes a while to mature and heal. So does bone, so does muscle. Anything that's had a trauma to it, it takes time. Bone, for like complete, and it depends on the density of the bone too, by the way. For like a bone, like, say you broke your ankle or whatever, it gets fixed. Now it's in a position where it can heal. Well, what we know about bone is it takes at least, for remodeling. Now, I'm not talking about healing to where you can walk on it and all that kind of stuff. But for remodeling, it takes about a year.
I see.
For that whole thing, that whole process to happen. Bone, muscle, skin, tendons are like, tendons take longer than muscle because tendons are not as vascular. They don't have a good blood supply to them like muscle does. So if you think about, like, if you've ever looked at an anatomy chart on muscle is red. It's beefy, right? Great blood supply. Tendons, what color tendons? If you look at
white.
Yeah, they're white.
Yeah.
Okay, so they don't have as much vascularity to them at all.
Yep.
That's oftentimes why people will get a rotator cuff tear in their supraspinatus, is because, and it's on the tendon, and they get what we call, what's the term? There it went. Tendinosis, which are perforations in the tendon.
Okay. I always think of the tendon as almost like a rope, like there's not much. It's like it's almost like obviously it's still it's an organism, like it's still living or whatever, but just sort of like there's not much going on there except it's just like a connective thing.
It's a connection point. There is a little bit of give to it, and you can do some myofascial release and deep pressure release to tendons and help them. And I do that on people, like if they come in and they're extremely tight. Only on the tendon, the muscle belly itself feels okay. I'll do some work. I'll take my same tool, but I'll take the silicone attachment off of it, and we'll hit it. And I wish I would have brought it with me. I didn't bring my tool with me, but it's like this stainless steel tool. It looks like a torture device, but it has a hook on it. It goes back like this, and they call it the Mohawk.
Okay,
that's the name of it.
Do you hook the tendon and pull?
No. Well, you can if it needs it, but most of the time, what you're going to do. And again, this goes back to fascial layers and everything else. But what you're going to do is you're going to take the ISTM tool, and imagine this is the blade on my finger, like kind of where I'm going across, but you're moving it back and forth along the tendon. And you can go this way, you can go that way, you can go all over the place with it. And what we find is that when we do that, we create a little bit of an inflammatory response at the tendon, which allows if there is adhesions and stuff in there, it brings awareness to the body. Say, hey, I need you to come in here and clean this up. Okay.
Oh, I see. Okay, so this is why about 8 weeks ago, probably 7 or 8 weeks ago now, I got a intercostal muscle. I don't know if it was a tear or what happened, but it was painful. It wasn't a cracked rib or anything, but it was like a muscle, something going on. And man, that thing is only now getting healed. Like it took like 6-7 weeks.
Yeah.
And but I was at Major Family Chiropractic, and Michael said to get like a butter knife and sort of just scrape it on the muscle in between the rib. And he's, because that would bring like extra circulation there and stuff like that. So that's what you're talking about.
That's it. So you did ISTM. That's what you did.
Oh, okay.
That you literally, when you took the butter knife, you did ISTM. They are very familiar with ISTM now.
Oh yeah. Okay. Did you get them into that?
I might have.
Nice. That's great.
I don't. Well, they may have done it before me, but
what are we looking at? I mean, for people on YouTube, they might be able to see this. Like, there's a skeleton with these. So this is connective fascia tissue. Is that what this is?
So, like, what you're looking here is actually a fascial line. Okay. So what it's representative of is fascia, muscle, and tendon, all the above. Okay. And what we're talking about here, and this is really crazy, and it's really cool. this is why I do my assessments the way I do them now, which is I'll look at posture assessment first, and I use the plumb line to give me a really accurate idea of where someone is standing, whether they're shifted to the right, left, look at their feet, what's going on down there, and everything, because all this stuff is actually connected. So if, say, for instance, I had a lady Monday, she was, let me get my brain on it here. She was shifted left with her head, left of the plumb line. And then if you look down, all the way down to her feet, her hips are shifted. Let's see, she was head shifted left, hip shifted back right. And if you look down at her right ankle was actually pronated. And pronation means the foot was falling in, right? It was just kind of going in. So what's really interesting is we're able to actually, it's crazy, but it's able to accurately identify which muscles would be weak based on her presentation, based off the fascial line here.
I see.
Okay. So to give you an idea of the muscles that are involved on this fascial line, so you have Tibialis Anterior, you have peroneals here. Then we have the tensor fasciolata that goes up into the obliques that then cut across. So rectus abdominis, which is the abdominal muscles, the 6-pack or 8-pack or 12-pack if you're chiseled like Michael. Sorry, I had to throw that one in there. That dude is stacked.
Yeah, he is. Yeah, he really is.
Anyway, so you go across to the other side, and then you have over here, you have this muscle called Serratus Anterior, which is actually one of my favorite muscles to talk about because it's one of the most neglected muscles in the shoulder. Anyway, besides the point. Then you flip it around to the other side. It goes into the rhomboids and back in here. And then it goes into splenius capitis up in the head. Okay. And that shows you how you're connected all the way up. What's interesting is she was weak all along this fascial line.
Oh, wow.
All the way up. How she was inactive. Okay. Where she had her posture deviations, she was inactive on all these muscles.
Wow,
every single
that's
one of them
crazy.
tested weak. All of them.
And is this connected as in like there's literally a string that goes from the ankle up the side and comes around, or is it connected in like you have muscle everywhere and there's just sort of a theme or a vein that you can sort of track through if you do it right? Like how connected is this?
It's really connected. So they actually have done cadaver studies where they have dissected this out of people. This isn't like, I'll actually show you an example because it's actually in here. And by the way, for those wondering, this is Anatomy Trains. This
Anatomy
is
Trains by Thomas Myers, Myofascial Meridians for manual and movement therapists.
Yeah.
Okay.
A lot of people thought Tom was crazy when he first came out with this stuff. And, some of my colleagues would probably say, like, oh, you've gone off the deep end, dude. What are you thinking about? But truth is, it helps.
Oh, yeah?
I have helped a ton of people.
So even in your practice, this book is like, ooh, that's getting out there a little bit.
Well, I'm not in my practice. It's not not for me.
Sure.
But for a lot of, I think outside the box a lot.
Okay.
Is why I do things the way I do them.
Yep.
Is because most of the people, when they come to me, they have a lot of times they've had physical therapy. They've tried other things, or maybe they've done personal training with someone else. They've gotten injured. They haven't healed all the way back, or they had an injury prior, and now they're really health conscious, and they want to do things the right way. So for me in my practice, this has been a way for me to kind of streamline and figure out, okay, the body's connected. Okay, when you do a lunge, right, there's a lot of stuff going on with a lunge, right? It's not just that you're working your quads.
Mm-hmm.
If you do it right, it's not. If you do it wrong, you could possibly be just using your quads, but then you're putting pressure on a lot of your spinal segment joints.
Mm-hmm.
Your toe is inactive, so now you're pronating your foot in, which then could probably lead to rotation of the tibia, which is the bottom bone on the lower part of the leg, which then cause rotation in the femur, and it'll put pressure on your meniscus. Yeah, you could eventually tear your meniscus doing that. You do enough repetitions, you turn that thing into mortar and pestle, and now all of a sudden you have a problem.
Dang.
Okay. And
form matters.
Right. It does. And that's that's why I do everything with, I emphasize biomechanics with every single person. Most of the people that I work with and train or do physical therapy, like, again, it's blended with me. I use those terms almost interchangeably. They're not the same. But how I do stuff with people is physical therapy with a training emphasis. Okay. So
yes. Okay.
we get them moving, start loading the body, and then off they go. Mm-hmm. And I'll tell you an example of why that's important here in a little bit. But biomechanics is insanely important. Your body was designed to move a specific way, right? These joints that we all have and we have a lot of them. Okay, I don't remember the number anymore. It doesn't matter to me anymore. So I just look at people like, okay, here's our movement deficits. Here are our movement deficits. You're weak here. We need to start loading you here, here, here. Here are your goals. Like I want to gain 20 pounds or whatever. And we start generating goals based on that. So volume of training and all this other stuff comes into play. So it's very multifaceted versus the like do 2 sets of 15 reps of those ankle pumps.
Right. Yeah.
I could beat my head up against the wall doing that stuff.
Yeah.
It's not that effective.
Yeah.
But what is effective is if you look at the body as a system. You look at it as a system and program and train people and like do manual work as a system versus I'm just going to work on this shoulder.
Yep.
You use it as a system. Now, all of a sudden, you're making something change. So another, I mean, I have all kinds of examples, but a gentleman I worked with recently, he had basically a terrible shoulder arthritis, and he couldn't raise his arm past like horizontal at all. And so I started looking at the fascial line. One in particular was that spiral line I showed you earlier, right? And also the functional line, which is basically the opposite end of the spiral line. So I started activating him along the spiral line, which is the front. Okay, so we started squeezing the muscles on that, getting those to fire because he was weak there. I said, okay, we're going to fire these. We started working on those, and then we went to the backside, which is functional line, if I can find it.
And when you say like activating the muscles, do you just mean massaging the muscles, or do you mean doing movements that start to use those particular muscles along that fascial line?
Most of the time, it's actually activating and using them.
Using the muscle?
So firing them with resistance, body weight only.
Okay.
It depends on what stimulus their body needs, because not everybody needs immediately to jump into a weight. So
yeah, I see.
Anyway, so on him, we worked on this functional line. Okay. For him, he was like, yeah, it was his left shoulder. He's like, yeah, my right hip's always been tight. I was like, oh my God, it's your functional line. And so I stretch his glute on the right. And you can see how this crisscrosses, right? So it goes this way, it goes that way. Okay. So I stretch his glute. And he's like, yeah, I kind of feel that my left lower back, left lower back. And I said, okay, let's do 3 at 1 minute holds on that. And I kid you not, I had him do that, and he goes, huh.
Whoa.
That's easier. Fascial line.
Wow, you're messing around by like his hips or his buttocks on the muscles there, and that's immediately giving him a gain
bizarre
on his shoulders.
Yeah, it sounds bizarre.
It does a little bit, but also makes total sense. Like we are a connected body.
Yep.
Everything makes sense about that.
So this is an example of a fascial line. I believe it's a superficial back line. And this is actually another one of my favorite lines to work on with people. Because a lot of people complain of pain in the thoracic spine. They complain, thoracic is the upper back. They complain about it in the lower back, and then they complain about this funky pain going down the leg and that sort of thing. Sometimes that's actually a fascial line issue, not necessarily a nervy issue. Could be. And I have some different theories about what could be going on, even with disc and stuff. I can't tell you if they're true or not, but I just know I do stuff on people and it works.
Yeah.
So I don't have any research articles to give you on that. But basically, this shows you kind of where the superficial backline is connected. And you can see they superimposed it. They took this and they put it on top of the skeleton. But this was dissected off of a fresh cadaver. Okay. Fresh cadaver studies are actually very, very important studies because they're not dehydrated, right?
What's a cadaver? A
Cadaver,
dead person?
Yes. It is a dead person that's given up their body for science.
When you say fresh cadaver, you actually just mean a person that just died?
Yes.
Okay.
Very, very, very new.
All right. And someone like would give permission to, hey, if I don't make it through this or if I get killed unexpectedly, you can do. Like, is that... I think I'm like an organ donor on my license. I think, does that mean I've signed up to?
No,
it's different. So this would be like for someone.
At least I'm pretty sure about that.
Okay, for someone to get to be a cadaver in this situation, they would have given specific permission.
I'm pretty sure they would have donated their body to science.
I see.
Or I'm not don't quote me on this. I don't know.
Yep.
This is not my area of expertise. Yep. I've heard that people that were like possibly homeless, didn't have anybody or anything. I don't know.
Wow.
I have no idea if that's the case.
Yeah.
So Don't quote me on that.
Yep.
You might have to edit that out of the podcast. But anyways, so it's basically somebody that's donated their body to science for the most part.
Yep.
Okay. But what they do is if you get a cadaver that's, weeks old, well, that thing's dehydrated. Things aren't like the fascia itself is very water-based, right? Our tissues are actually mostly water-based, right? Like was it 80% of our body is mostly water, right? So think about it. If you set a piece of meat on the counter, it starts drying out. Right?
Yes.
Or at least
Quickly, actually.
It should, unless it comes from places that Michael and Cassie don't like.
Like McDonald's.
I didn't know if we were okay to say that.
And by the way, at their practice, they have like a gourmet like glass bowl with McDonald's in it. And are they trying to see how long it's going to stay in there, or what are they doing?
I think
it's real food, right?
Yeah,
I think it's actual McDonald's.
It's actual McDonald's. It's been there for what? How long? How long did you say?
It's been there ever since I've been there. I don't know. I assume they're just leaving it there to see what happens, but it looks pretty fresh, to be honest with you. It looks like
it's not decomposed at all.
Eat it. No, it's just, it's there. No. Yeah, it looks great, actually.
Even if it's like in a container, it doesn't matter. Like we've all had bread in a container. Bread goes, pfft.
Yeah.
That stuff does not.
Yeah.
It's just, that's just
concerning for sure.
But anyways, so the reason fresh cadavers are important is because it allows us to get a more accurate representation of how the body is interacting with itself.
Sure.
Right. So these studies are done on fresh cadavers that still are hydrated. So therefore, they're able to actually get these fascial lines more accurately. Okay. And there's actually a course with Tom Myers where he takes you through dissection of a fresh cadaver. And you go through all the fascial lines, you actually physically get to see it, which is pretty cool.
Yeah, that is pretty cool. That'd be fascinating. Now, let me ask you this. So when I got this intercostal muscle rip, tear, strain, whatever it was, there was someone in the gym that mentioned there was another lady in the gym last year, I think, that had also got an intercostal muscle injury.
Yep.
And for her, the pain was not so much in the rib, but it was in her lower back.
Okay.
Would that be, and since I've had this, first it was so painful, like if I would laugh, it would hurt. Breathing hurt a little bit and really couldn't do much at all with the gym with like above, like shoulder movements and arm movements, really didn't do any of that. So I just did legs for a little while and tried to like ride the bike and stay semi-fit, but there wasn't a ton I could do because of the pain. Feeling a lot better. However, when I was recently, we've been doing a little bit more hiking just with the kids and stuff like that. And I'll go out on a short hike and I'll feel lower back pain pretty quickly.
Yep.
So my experience coupled with this other lady's experience at the gym, when she had a intercostal muscle injury, she experienced it mostly in her lower back. Yep. Is there a fascial line connecting those two, or do you think there's any kind of connection at all between ribs and lower back?
The connection is going to more or less lie on. So I refer back to this a lot. This is still a very new concept to me.
Oh, really?
Yeah. I haven't been using this. I mean, I've been using it over the past year, year and a half.
Okay.
I mean, I first heard about it from this guy, and he's phenomenal. He's becoming one of the most prolific physical therapists in our profession. But he owns a company called Myodetox. His name is Vinny Fan, Phan, I think. If you look him up on Instagram, you can look up at Vinny Rehab.
Okay.
I think he may have changed it, but I think it's at Vinny Rehab. Myodetox at Myodetox. But it's phenomenal. Like I got wind of his stuff. I was like, what? And then he had this book. I was like, what the heck book is this? And then finally, I caught a like a picture or something that had like what the book was in it. I was like, I'm going to order that book.
Okay.
And then I ordered it and I started implementing it. And this is actually, gosh, it's been longer than that. Good grief. Because I started doing this before I left the hospital to do my business full time. Okay. So I've been using this for like 2.5 years now. I didn't realize that.
Yep.
But anyways, so there is a connection. Yes. The connection is probably going to lie in a couple of different ways. Okay. So if we look at intercostal muscles, this actually does go up into the intercostals, which then goes the spiral line. It hits the intercostals and goes back into Serratus Anterior, that shoulder muscle that I really, really like, that I was telling you about. And it goes back the other direction. So if you have a weakened muscle on one side, could it be that you're compensating on that side? And the only stability that you have then could be from lower back. That being said, also, if we look at the other side of the spiral line, we do have right here, iliostalis and spinalis. Okay, those are the two, like, call them back straps, right? They go right down the middle of the back. And again, this is why I refer back to this thing, because I'm like, I don't know all this stuff by heart.
Yep.
I know the concepts, and I know where to find the information.
Yep.
And I know how to implement so that I can fix someone and make them better. But yeah, I would venture to say most likely what you're dealing with there is because you have a weakness here. It could have manifested back here.
Sure.
Certainly. Yeah.
It makes sense. Now, what do the people, when you say not every physical therapist is going to be in on this, or maybe even believe in some of this, what do they say? No, there's not a what's the term, meridian? Because a meridian is the meridian the actual
it's
line?
The line.
The meridian is the line. Yeah, that's what I thought.
Line.
I've heard that before, but I don't know much about it. Do those people say no? There's no such thing as a meridian. There's just muscles everywhere. There's not like a stream of muscle that's connected. What do they say?
Most of the time, that's what they're going to tell you. They're going to say you're not, like, your head's not connected to your foot. I'm like, of course it is.
Okay.
Like, I mean, if you think about it, if I just start at the top, and like, if you could see my feet, if I stand up, like, if you can actually see my feet, if my foot turns in and I only move my foot in like this, well, my hip's moving.
Yes.
You can see my hip is moving.
Yep.
If my hip is moving, then something else is moving on top of that. And then I have to stabilize. Well, where am I going to stabilize? Probably across my body, because that's how we are built. We are built in not a linear function. We do diagonal stuff all the time. How do you lift? Most people, when you're lifting a box and moving it, you lift and you twist and you set something down. So you have to load across systems. So it makes sense then that you would have to have something that's going to stabilize you across the other way, right? The design has to be there for it. In fact, thoracic spine actually has a lot of rotational mobility to it. It's got a lot of movement that way, okay? Mostly through the rib cage and everything like that, but it has a decent bit of movement. But then again, like, you start doing that, well, what have I just done when I, like, say I've activated here, or I rotate this away? Well, yeah, sure, my shoulder blade just moved back here. Well, my shoulder blade just moved, which is, like, I have levator scapula that's right here. I also have spinalis that runs up the back of my neck. You can see that muscle right here, okay? Or splenius, muscle that connects all the way up to the head. So yes.
Yeah.
We are connected.
Yeah, it's got to be. And that's why, what is the term for this? People that do like a particular type of foot massage and it affects the body. Reflexology?
Yeah, reflexology.
Is it reflexology?
Yeah.
Is that what it is?
Yeah, you nailed it. Yeah.
Okay. Yeah, my wife's mom does that, my mother-in-law, and she's not super trained. I think she's taken some classes on it, but basically that manifests itself in a practical way, which is she just gives a really, really good foot massage. So I have no problem. I don't even know.
You don't care.
I don't
just
care.
Feel good.
It's a great foot massage, but it is like, it depends where she finds like different crunchies in your feet. She's like, is your back hurting, or like stuff like that? It's like, well, that feels sort of weird, but of course, why not? I mean, if the muscles go into your feet and your body's connected, which it is, I can at least, appreciate an argument for there being a scientific backing for why that stuff would work.
Yeah. The research has been there. We've just ignored it because, truthfully, I don't know why we do this as professionals, but a lot of times there's banter back and forth. Well, the McKinsey camp, well, the Mulligan camp, well, this camp. Well, I don't care. Does it help somebody? That's all I care at the end of the day is, can I take a client and make them feel insanely good?
Yep.
That's the whole point of why we exist.
And following this, you've been able to help some clients with this line of thought. Yeah.
Oh yeah, one guy in particular I'll tell you about. He's I started him last November, so it's been almost a year working with him, and he's one of my training clients. I see him 3 days a week because again, people need loading again and again, and this is not the traditional physical therapy. Right? Traditional physical therapy is going to see you maybe 8 weeks, twice a week, 1 to 2 times a week. For 8 weeks. That's the script that most of the time we get.
Okay.
But the truth is that he needed loading over time. The problem was he would go, his knee would be feeling good, and then he would go work with the trainer. And no offense to trainers, but some of them don't know the best biomechanics. They just don't. They're not educated in that. I have my doctorate in that. So what would happen is he would start doing okay. He would start off light because he physically could not do it. He would just be so short-winded and not able to perform all the activities. But then as he got stronger, he's like, I'm more confident. I can do this better. And then he would get overloaded and bang, there's an injury, like a legit have to go have surgery injury. It blew something out. And then all the weight he had lost, he gained it right back and then some. And that happened, I think, 2 or 3 times. And then he finally was like, oh, crap, I don't know if there's any hope for me.
Mm-hmm.
And it was that was really, really sad to me. When he came to me, he was just telling me, it's like, man, I want a trainer that can actually understand my body, understands my injuries, understand what I need physically, and kind of help guide me on the right trajectory for my body so that I don't have to have any more of these surgeries. I know I need to be physically active, but I can't because something always happens.
Mm-hmm.
And so utilizing the principles of myofascial lines, biomechanics, along with the myofascial lines, we're able to take him on a process to where he's now, I think he's 65 pounds lighter.
Oh, wow.
And he has had no injuries for an entire year.
Okay.
And it's all based on biomechanics.
Yeah.
And understanding how the body is intimately connected with itself. And if I showed you his posture, and I wish I could, if I had a disclosure agreement with him, I could show you where he was versus where he is now. It's insane to look at what happened with his posture. And again, I talked about that with the myofascial lines. What happened with his posture, he had like a major anterior pelvic tilt, like his low back looked like this. It was bent really bad. And like over the course of strengthening and loading, over time, he got taller.
Oh, I see. Sure. Yep.
Just based off of...
Was he bent front, you mean?
Yeah. Well, he was like the best way I can do is just show you. So basically he went, I think, if I can get this right, like this. And he had a lot more weight, so his belly stuck out quite a bit.
Okay.
And then he was kind of right here.
Sure.
Thumbs pointed at each other.
Okay.
Right. He thought he was okay in a good position, but if you look like from the side,
right,
like my back is hyperextended.
Yes.
In this position.
Yep.
So I mean, I'm loading L5, S1, which consequently he also had back pain.
Sure.
He doesn't have back pain anymore.
Yeah. Wow.
Because we took him on the process of balancing out his body with biomechanics and then loading over time.
Yep.
Which again, that's where my practice differs from traditional physical therapy, is that I don't really like the idea of just seeing somebody twice a week for 8 weeks and then bye-bye, see you later, good luck.
Right.
You need to load it. If that's with me, great. Yeah, I have space in my practice to where I can do that and I can take you there. However, if that's not for you, that's fine. I'll give you the principles. You can go off and do your own thing if you want to. But oftentimes people need the neuromuscular re-education, which is just connecting the brain back to the body through these fascial systems and everything. See. So they move right.
And when you say they need to load it, you basically mean they need to do particular exercises to accomplish what you're trying to accomplish.
Yeah, I mean, particular
exercises. Is that what you mean by loading?
Loading means basically like taking somebody through a strength training process.
I see.
Right. Yeah. So loading as in, we started with him a barbell on a deadlift.
Okay.
Yep. And now he can easily do, I think, 135 on his deadlifts, but multiple, like I'm talking like 3-4 sets of 20 on those.
Yeah.
He's crushing it. No back pain with it either.
So. Wow. Yep. Now, when you say like an injury, so like the one category of injury, I feel like I can just kind of understand like this happens, whereas like you have an advanced athlete and they're pushing it. If you're into CrossFit, like Michael is, and you're getting heavy weights and heavier, and one day you injure yourself because you went too heavy or you went too hard or whatever happens. Yep. Like, so there's that. But then there is another category where someone's body they're out of shape or they're weak in certain areas or they've had other injuries, and just like certain types of everyday movements they can actually get an injury from. It sounds like that was maybe this guy's case, or when like he didn't sound like he was getting injuries because he was an advanced athlete.
No, he
was getting injuries because he was out of shape. And so it's like he would try to move and be active, but just that amount of movement would cause an injury.
Yeah, it would, but it was also the biomechanics of how he moved also.
Okay.
So how he was being taught how to move. So, I mean, I teach people when you squat, I'm sure you're very familiar with this. You plant the toes, create a slight bit of arch in the feet because that puts the knees slightly outward in external rotation to the hips. And then pretty much, it allows the knee to track the way it's supposed to, which the knee has a mechanism called the screw-on mechanism, where it literally screws back into itself. And that's kind of a weird way to put it. But the very, very last end of knee extension, there's a locking like this. That's what you say. They say, don't lock your knees. And that's what I'm talking about. There's actually a lock right there on end range. It's very hard if somebody has a decent bit of strength to unlock that. If they have a decent bit of strength, because of the locking mechanism.
I see.
Think like pit bull, when a pit bull locks down on something.
Sure.
Same idea.
Oh, jeez.
It's very hard because they have a lock mechanism in their jaw, right? And we have a locking mechanism. It's not that strong, but that's the principle. Well, what happens is when you unlock, some people will let the knee cave in. And I know you're doing CrossFit or doing any kind of type of weightlifting, they tell you don't let that knee buckle in, right? That's one of the most common cues. Well, the thing about it is, unless you're correcting down below that too at the ankle, you could inadvertently be not necessarily buckling in, but you could be rotating the tibia in, which is creating the same thing just on the bottom of it. Okay. And that's oftentimes what I look at with people is we're looking from top down, but we have to look at the ground up too.
Sure.
Got to look at both.
Yep.
So for him, it was biomechanical. Like I had to correct everything about his movement patterns. He also, side note, he had triple orthodesis in both feet.
I see.
So,
Yeah.
Which he was a mess.
What's an orthodesis?
That's basically where they fused his foot. He has no inversion or eversion.
Oh, jeez. Wow.
I say no. He has a little bit of motion, but not a lot.
Sure.
Not like you and I. Like I can put my foot up here and I can turn it in like that easy.
Yep.
He's got like that much.
I see.
That's it.
Okay.
And then about that much.
Okay.
That's about all he's got.
What was the muscle that you mentioned? Shoulder muscle. That's one of your favorite muscles you mentioned.
It's Serratus Anterior. So have you ever seen somebody in a push-up position? Their shoulder blades look like they stick up like this on their back.
Yes.
Okay. Most of the time, that Serratus Anterior is weak. It looks like the cat at the zoo where the cat's walking around and its shoulder blades are like sticking up like that.
Yeah.
Okay, that particular muscle is called Serratus Anterior, and it's very important. So overhead motion, 1/3 of all overhead motion is accounted for by the shoulder blade itself. Okay, so if you're reaching overhead, 1/3 of all that motion came from your shoulder blade. Okay.
When you say shoulder blade, you mean the shoulder blade muscle?
No, the bone.
The bone.
The scapula. Okay, it's this muscle, or not muscle, the bone right here. So
sure.
I'm going to turn around in a second. I'm going to just move my arm so you can see it.
Yeah. Okay. Yep.
See that moving up and down? Okay.
Yep.
So that was actually my scapula moving. Muscles attach on that and fire off it. The rotator cuff actually attaches to the scapula. Okay. Anyway, the reason that's important is that particular muscle does what's called upward rotation. Based on where it attaches, it's on the ribs. It attaches on the underside of the shoulder blade, and it pulls. The angle that it pulls at, because it pulls on the bottom end of it, it causes the shoulder blade to do this.
Okay.
And it upwardly rotates. It also does this motion called protraction. Okay. Protraction goes like this right here. Okay. So when you're in a push-up position, this is why it's important. When you're in a push-up position, if that muscle's weak, it pops up off of the back. Pretty easy to spot.
Now, what do you mean the muscle? The muscle doesn't pop up off the back, but the shoulder blades do.
Yes, the shoulder blade
because
does.
The muscle is not strong enough or developed enough to hold.
Right. It can't stabilize you. So like when you get in a push-up position, like if I'm here on your table and I get there, I don't know if I can do this very good because I do a lot of push-up position stuff. But if you're here and those shoulder blades are popping up like that versus more of this position, which is stacked.
Okay. Yes.
Okay, that's a much more stable position than just letting those shoulder blades sort of fall out.
I see.
And again, the reason that's important is if we get into overhead motion, there's a lot of things that can go wrong there, right? If that shoulder isn't, if that particular muscle isn't firing right, you can get what's called impingement syndrome, where you're basically pinching on the rotator cuff tendons going overhead. There's an arch that's there. It's called the coracoacromial arch, and the head of the top, or the bone here, which is the humerus. If that doesn't slide under that well, it'll actually smack up against one of the tendons there called supraspinatus. You can also hit the biceps tendon there as well, and you can cause some tendonitis as a result of that. So some people kind of like this pain like right there, it hurts. Well, sometimes that's as a result of a winging, it's called a winging scapular or scapular dyskinesia as a result of a weak Serratus Anterior, or some of the supportive
Where
muscles.
is the Serratus Anterior?
So that'd be this guy right here.
Because you mentioned, I think you mentioned something about it being a shoulder muscle, correct?
Yeah, it connects to the rib cage though, so it's not just a shoulder muscle. It connects to the rib cage, and it's right here. Let me get, my fingers are too big for that to work, so it's right here. Okay, so you see this little bump right here? Okay.
Yep.
That muscle actually cuts around. You can see it coming around here like this.
Okay.
It forms in and attaches right there. Okay.
Okay.
By the angle pull, if I pull like this, what's going to happen to that shoulder blade?
It's going to pull the shoulder blade out.
It's going to go like this. It's going to sweep around and give it upward rotation based on the angle of pull.
Mm-hmm.
Okay, that's very important. Everything's based on the angles that it pulls on. So if you, I know what I was going to tell you. If you've ever seen boxers, right, and they're throwing a punch, like, say they're throwing a punch like so, you'll see that fan that comes right there, that fan muscle that looks like right on the rib cage.
Oh,
just have Michael do like this for you. You'll see it. It's easy. Okay. Yeah. But have them punch out like, dude, let me see. Like,
that's the muscle right there.
Yeah, that's the muscle.
Oh, okay.
It goes right on top of the rib cage. It's right there. So you have intercostals that are up under that. Those are the muscles that go in between. Okay.
Yep.
These lie on top. You see how it's just kind of laying on top like this.
Okay.
It lays right there, and it contracts on that, and then it pulls on the shoulder blade right there.
I see.
It's one of my favorite muscles. I really like that.
And why is it one of your favorite muscles?
Because it's often neglected.
Oh, really?
It's easy fix.
Okay.
It's like such an easy fix to start working on that for people with impingement syndrome and other stuff like that. You literally can get people in like a modified push-up position. You can have them just do shoulder protraction.
Oh, okay.
Just like that. In a pain-free range, you can do it. You can get a band.
That starts to build it stronger?
Yeah, it starts to make it
What
stronger.
can people do to build this muscle stronger? It sounds like it's an important muscle.
Yeah, so you can do scapular protraction. You take a band and you can like throw it around your back. Like if you have, say, a pull-up band, right? Just a regular pull-up band. Throw it around your back, hold it on the side. You can hold it right there, and you can just literally punch like this. Pause. Okay, you should feel when you do that, like feel along your rib cage right there.
Okay.
You should feel a tiny, small contraction right there.
Yeah, I can feel that. Yep.
Okay, that's that muscle. Okay.
So if they just work that strengthens the muscle.
One way to do it.
Yep.
But you start getting more complex. You can work fascial lines and then get it even better.
Oh, okay.
That's where it gets fun.
Yeah. Do push-ups strengthen that muscle or not so much?
If you do them right, if you just do a push-up like you just let the shoulders fall, it won't do anything to it.
I see. Okay.
Because then you're just relying on the joint for stability versus muscles.
Okay.
Which is a lot of what I teach people. A lot of people are utilizing joints, the joints for their stability versus utilizing the natural shock absorbers, which are your muscles. Like they're really good at taking load if we load them. But oftentimes, like my client I was talking about, the guy that lost a lot of weight, he was standing like that. So he was loading his L5S1 all day long. Yep. Or not all day long. He sits a decent bit, but when he gets up and walks around, he would load that. Or when he was doing exercise, he'd be like this.
Yep.
So he's constantly just jamming the facet joints, which are the joints in your back that articulate with each other. He was just jamming them up all the time. So.
Let's zoom back out and kind of give people an overview of what it is that you do and how you got there.
Yeah. So, gosh, I'll start with the story of how I got here.
Yeah. You from Nashville, by the way?
No. I'm actually from Arkansas.
No way.
Yeah. I'm a
Razorbacks fan?
Yeah.
My brother-in-law is hardcore Razorbacks fan.
We're finally starting to get some traction in football.
Oh, really?
Jesus. Yeah, I call it the curse of Bobby Petrino when he was there. We were great. We were like top 15.
Okay.
And then there's the whole fiasco. You can look it up. There's like a whole fiasco about it, and he ended up getting fired. He had long story.
Now his curse remains.
Yeah, and like for the next 3 coaches, I mean, I'm talking about, and they just, the way Arkansas is, they don't typically fire people very fast. And anyway, so I think we finally have a good one. Like we beat Tennessee. I mean, come on.
Oh yeah, who hasn't? I don't know how they're doing this year.
Hey, I'm just saying that's a big deal for Arkansas for the past 5, 6, 7 years. It's been awful.
Yeah.
But yeah, I'm from Arkansas originally. We moved to Nashville back in 2015.
Okay.
We moved literally on our anniversary.
Okay.
Which June 12th. and we moved in 2015 to Hendersonville. Lived there. I worked for a local company here, and then I ended up. It was one of those things, I was just kind of praying about things, and I felt like I needed to do something different. How we got to Nashville is a really long story for another day. But I started working for this local company. They're outpatient, orthopedic type, typical traditional physical therapy clinic. Started working for them, and I was like, I wasn't really happy. I was like, man, I got to do something else. And the way they operate, they typically see about 2 or 3 people at a time, like that. Especially not if I'm doing
one physical therapist sees 2 or 3 people.
Yeah,
at a time?
one physical therapist will see 2 or 3 people, guiding them on exercise.
You try to get the 2 or 3 people that have the same sort of problem.
Not necessarily.
Or it's like,
That's where it gets
you just
really
kind of
hard.
go back and forth.
Yeah.
Okay.
Sometimes it feels like you're herding cattle or cats, depending
Sure.
on what type of people you have.
Yeah.
It did anyways. So I was like, man, I can't actually serve people like this. And for me, if I'm going to do something, I want to do it well. That's why I've studied all I've studied.
Mm-hmm.
If I'm going to serve people, I'm going to serve people like the absolute best that I can. I'm going to give them the best that I have.
Mm-hmm.
So even when I was with the former company, I served them as best as I could. But I'm limited on what I can do because I'm seeing 2 or 3 people at a time. And so I was like, I got to figure out how to find a place where I can see people 1-to-1.
Mm-hmm.
And that led me to a hospital system that I worked for the next 3 years. And it was great working for the hospital system. There are good people. I saw people 1-on-1. I was able to affect a lot of lives that way and significantly help people. The trouble was where I was working, the demographic wasn't that concerned about health and fitness and everything. So I was very limited on what I could do and what they wanted to do. It was just kind of one of those mindset things that, the folks didn't really care about it. They had like a very high rate of obesity, high diabetes, and everything like that. So clearly, they're not that concerned about their health, and it's not trying to demean that particular area. They're just not as focused as the clientele that I work with now.
Sure.
Yeah. And I was like, man, I would love to have my own thing with people who are extremely motivated that want to get after it, and they're like. They come in and they've done their exercises and they're doing this and that, and they're asking questions. And I love it when people are engaged.
Yep.
Because they're engaged, I can help them.
Yeah.
Like 99 times out of 100, I can help them. And the one time is like, oh crud, that was going to be hard for anybody to help you. And actually, you did need to go see another person.
Yeah.
And so you refer them out. But anyways, how I got started, a friend of mine, he's a gem of a human being. I love him. I still go out and have lunch with him, and he's done very well for himself. And he's been able to bless a lot of people. One day he rang me up. He's like, Dustin, can you come to my house? My hip is like, I'm dying. I was like, yeah. Anything I could do to help you. You've been so kind to me, and so gracious. And he talked to me through a lot of stuff. And anyway, one day I went over to his house. I was like, hey, I can come over Tuesday. He's like, great, Tuesday's perfect. I don't have anything going on, so come on over. So I went over to his house and brought my table. This was when I was doing mobile sessions only, and right when I started, I was doing mobile sessions only. And I worked on his hip, made his hip feel amazing. He's like, oh my gosh, thank you so much. Now I don't have to go get a shot in my hip.
Yeah.
Because I was thinking, God, I don't want to get another shot in my hip.
Yep.
And so fixed him up, made him feel great. And he looked at me, he's like, dude, why are you still working for other people? And it was one of those, it was a God ordained moment, right? He just looked at me, he spoke with such conviction. He was like, you really don't need to do this for someone else. You need to do this for you because people like me want to work with people like you. And the nature of my business, it's just kind of how it went. I ended up working, I've worked with a lot of very successful people, a lot of successful businessmen. I've worked with country artists, rock artists, and Christian artists, and other things. And that's not to boast or anything. It's just how chips fell. Anyways, he goes, dude, you got to do this for yourself because there are a lot more people like me that need your help. And I said, really? He said, yeah, there definitely are. And we definitely would want somebody like you. And I said, okay. So that started the idea. And so I started looking around because I knew.
Was that the first, like, you had put serious thought into striking out on your own?
Well,
Did that kind of reinforce what you were already kind of thinking about?
A long, long time ago when I went to PT school, I was thinking it'd be neat to have my own business.
Okay.
And I was like, well, it'd be fun, it'd be cool. And then I got to PT school. I'm like, ain't no way I'm doing this, because we did. It's crazy. In school, they teach you the how to run a business, which basically consists of you taking out at least $100,000 loan for a business loan and doing all this other stuff.
I see.
Which is totally not how I built my business.
Okay.
Like at all. I have not taken out a single like SBA loan or anything.
Yeah.
I've just built it from the ground up.
Yep.
And anyways, so I was like, no way I'm building this business. I don't desire to do that. I was like, that's too much work. And when my friend told me that, something tripped on the inside of me. I was like, he's right.
Mm-hmm.
I should go out and build this thing.
Yeah.
And ended up, I started Googling and looking around. And I liked the concept. I'd heard rumblings in PT of this concept called concierge physical therapy. And I was like, what is that? I don't know what that is. And then I was like, well, the closest thing I know of that I've heard of is concierge medicine. And so I said, let me look up concierge medical doctors and see what they're doing. And then, so I Googled around, found this guy. His name is Dr. Aaron Wenzel, and just without a doubt, one of the biggest influences on my business. Without a doubt. I love him to death. He is such an incredible human being and a fantastic physician for those that are looking for that type of service. He's a private medical doctor. He has a nurse practitioner who works for him. I'm like, dude, you're doing in medicine. I basically, here's what I did. I sent him an email and I say, hey, doc, I'd really like, so I was like, first of all, your website's amazing. Secondly, you're doing in medicine what I want to do in physical therapy.
Oh, okay. Is this guy, was he in Nashville?
Yeah, he's in Brentwood.
Oh, yeah?
He owns Brentwood MD.
Brentwood MD.
Mm-hmm.
I kind of feel like I've heard of that.
Yeah.
What was his name again?
Aaron Wenzel.
Aaron Wenzel with Brentwood MD.
Yep.
Okay.
Yep.
All right, cool.
Amazing guy.
Yep.
And great friend of mine. We text every day now.
Yeah.
But anyway, I sent him an email. I was like, hey, doc, I mean, you know me from nobody. I don't know you. I'm not asking for a referral at all. You've built something that I want to build in physical therapy. As a business owner, you're a business owner. I just want to learn from you. Can you teach me, can you give me some information as to how you got started in doing this? About 2 weeks later, I got an email back. It's like, Dustin, this is an incredible idea. I love your thought on that. I love that you're trying to do this in physical therapy. Let's grab lunch. And normally when you do physician marketing, you buy the physician's lunch. No. I went and met him for lunch. I got to pay, and I was about to hand them my card. He said, no, your money's not good today.
Yeah.
It's like, it's on me. I was like, really? He said, yeah, no, I'll get the next one.
Yeah.
And we sat and chatted for at least an hour, and it was incredible. Instantly, I was like, this guy is basically in the medicine field what I want to be in physical therapy.
I see.
And he looks at things from a biochemistry and like medical standpoint, the way I look at him in the physical standpoint.
Okay.
He's an incredibly great guy. Happens to work with a lot of successful business owners and stuff too. But yeah, he was he is, I would say, the biggest influence on my business as to how it formed and how it grew.
On the business structure and the type of business you're looking to build.
Yeah.
Okay.
On the business structure, the types of clientele that he has. Again, he works with a lot of business owners, a lot of very successful people, and I really love to work with those types of folks.
Yeah. How'd you get into that? How did you get your name out with some of the country music artists and rock artists and, I guess like even celebrities, excuse me, celebrities to some degree. Like how'd you break into that?
Well, I mean, honestly, part of it was through my relationship with him, through the doc, and then also through some other folks as well.
Okay.
Just honestly focusing on serving people well.
Yep.
And just focusing on how can I improve.
Okay.
And like keeping my eyes on my vision, which has always been from the get-go, like and I hold no bones about it. My vision was to create what I would call a luxury brand of physical therapy.
Oh, I see. Okay.
And when I say luxury, I mean, like, if I were to go to physical therapy, that's what I would want.
Yes. Yeah.
Right. That's what I mean. Versus what I've seen out there right now in a lot of other places. So yeah, it was just a matter of continuing to sharpen and improve and dial in what I do now, which is a complete biomechanical assessment. And then we figure out exactly where the problem's coming from and start crafting a solution to take people from what I say painful to pain-free and fit.
Mm-hmm. Yeah. And so the 2015, you had the conversation with the gentleman that called you over to do some mobile therapy, correct?
I think it was 17 I actually had that.
Okay. When did you actually strike out on your own then?
It was like 2 months later. I was
okay. Okay.
I was
Pretty quickly.
Yeah. Well, one thing I figured out, and he hit on this a lot. So I went to his house probably 2-3 more times, and he's one of the most successful people I've ever met. He's incredibly successful and just like I told you, just a good guy.
Mm-hmm.
And he looked at me one day. He goes, Dustin, he was like, you need to do your due diligence. Like I was getting caught in like the details of everything. Like, do your due diligence, but I'm going to tell you right now, I ready, fire, aim all the time.
Okay.
He's like, I fire before
That's
I'm
so
ready.
much more fun.
He's like, I
Ready,
fire before.
aim, yeah.
Yeah, it's like I fire before I'm ready all the time. It's like it's way more fun. It's like, yeah, you miss sometimes, but truth is that if you have a gut feeling, you go ahead and pull the trigger. Oftentimes you beat everybody else at the punch, and you create something that people truly wanted. And I was fortunate enough to set out and do that, and created something that's really special. 38 sessions this week. So
yeah, that's getting after it.
Yeah.
And what are the sessions? Like how long are they generally?
They're an hour.
Okay.
So at least an hour. Some of them, depending on the nature of what's going on, I have to do a little bit longer. So I'll do manual work on people and then maybe go into the training portion.
So hold on 1 second though. You came over here at 3:00 on Wednesday. And by 3:00 on Wednesday, you had 38 1-hour sessions.
No. I'm talking about in a week, like 1 hour. No, I'm talking about an entire week.
Oh, you're planning to have 38 sessions this week,
right? And it actually went to 39 because I had a new consult come in today.
Okay, gotcha. Yeah. Okay, so you haven't done 38 hours of therapy by midday on Wednesday.
No, not today.
I see.
I don't know what I'm at yet. I'm somewhere halfway there.
Yeah. Okay.
I don't know.
But you got plenty of business the way it sounds.
Yeah.
Is your shop it's in Franklin or is it Brentwood?
Yeah, it's in Franklin. Actually, sublease out of a studio down
Okay.
in Franklin. It's called Fit Studio.
Okay.
The owner of the studio is Amanda Fullen. She's an amazing human being. Has been so gracious for me to use her space and to grow my business.
Yep.
And it's just a nice private training studio, very low key. And we like it that way.
And
And my clients all love it. It's very clean. We have all the equipment that we need, and we're able to really hone in. Clearly, obviously, we're able to get results for people. Otherwise we wouldn't get business.
What portion of your kind of average weekly business is physical therapy, and what portion of it is personal training? I know they blend together.
Yeah. People that are just going for personal training, it used to be like 25% maybe personal training, but it's truthfully, nowadays it's 60 to 75%.
Really?
Training.
Okay. So those are people coming in. They don't necessarily have an issue where they need a physical therapist.
Yep.
They want to get, bigger, stronger, faster, better in whatever capacity, and you're going to help them get there.
Yeah. Through a biomechanical process where we take them through loading strategies to prevent injury. So it's very much with the end in mind of we don't want to injure, okay, and we want to create something that's sustainable for the rest of your life. That's the goal. Is for most of my people, they're business owners, a lot of them. So they're not trying to lift 500 pounds or whatever.
Sure.
They're not trying to deadlift 400 pounds. They don't need to do that. What they want to do is, I want to get in the best shape of my life that I've ever been.
Okay. And they have like a select amount of time, and it sounds like they have some means, and so they're going to come to a personal trainer as opposed to joining a local CrossFit gym, basically.
Right. Yeah.
Okay.
Yeah, they will. A lot of them are, they're afraid to go to group fitness because they really want eyes on, and they want someone watching their movement patterns and correcting their movement patterns, and allowing them to do things the right way. And not saying that CrossFit is the wrong way, but they want to make sure that they have eyes on. I'm looking at how they move, and what's an appropriate weight for them, and helping them decide. And also, it's the accountability of it too. It's someone that they're directly responsible to. Some of them don't like being in groups, so they want the more personalized one-on-one care.
Sure.
And that's exactly.
And they'll
what we
come
do.
in anything from 2 or 3 days a week to 5 days a week, or
Yeah, I have. I just signed up another lady, and there's a lady I was talking about earlier. She just signed up for 5 days a week.
yeah.
And I've got a gentleman at 5 a.m. that comes 5 days a week. I don't think there's anybody else. Most everybody else is 2 to 3 days a week. For the most
You
part.
go in at 5 a.m.
Yeah.
to have a personal training session?
Until I get my hire on board, then she's going to take over the 5 a.m.
That'd be the first one I get help for.
Yeah.
I'd be like, I need some help. Yeah, I need someone from 5 to 8 a.m.
Yeah, for sure.
Hit as many sessions as you can, then I'll be in later.
Yeah, that's right.
What is the difference between physical therapy and chiropractic care? Maybe actually the better way to put that is, if someone's dealing with an issue, how should they know whether they should go to a physical therapist or a chiropractor?
So that's a great question. And I don't know the best way to answer that. I know what I do, the thought process that I use is we have similar ideas, because we want the body to be aligned and we want the body to move with certain mechanics and everything like that. I don't do adjustments. I don't do that. I will do mobilizations where we're gently like moving the joints and things like that, but I don't actually adjust people. What I do is basically, that's what I tell people. I connect the brain back to the body with movement. That's what I do. In essence, sometimes that requires me to use manual means to get there to where they can actually do that. But yeah, that's definitely more or less what I do.
Okay, so you're not going to, crack people's back and their neck and stuff like that. However, if someone comes, it would be reasonable to think someone's going to come to you for some physical therapy because of, let's just say, lower back pain, right? That happens?
Yeah. Oh, yeah.
Okay.
All the time.
Some people might go to a chiropractor for lower back pain, but if they're coming to you, you might do some massaging and you might try to move this, loosen the spine or something. You're just not going to like adjust it like a chiropractor would.
Not really. No. I mean, I'm trained in what we would call high velocity, low amplitude thrust techniques. I am trained in that. I very rarely do any of that stuff.
Okay.
It's just I don't have as much experience in it, so I don't gravitate towards it. I gravitate towards what I know, which is I know how to move people.
Sure.
I know how to move people really well. And so what works really well for me is taking people through a process to where we can calm down the tissue, whatever it is. If it's a muscle, if it's, a joint that's not moving properly, calm it down, make it where it doesn't hurt as much, and then start putting them through the process of loading it so we get rid of pain. And I use different techniques. I use dry needling, which is the acupuncture needle where we stick it in the muscle. And we can either do pistoning, which is pushing the needle in and out on it, or we can hook it up to an E-stim unit. So you actually have intramuscular stimulation.
Okay.
And
is the thought process there, if you loosen the muscles and get the muscles how they need to be, the bones will then fall into place, or the spine will then fall into place?
So not necessarily loosen. It depends on what the body needs, right? So everything's based on assessment. If it's a tight muscle that needs to loosen, yes. Sometimes tightness, though, is actually the brain's response to, I need something to change. This muscle is actually weak, so I'm going to make it feel tight. And I can tell you how many times I've taken people like that have tight hamstrings, put them through deadlifts, and you're going to stretch a little bit when you do deadlifts, but I'll take them and we'll work on strengthening, like eccentric, not always eccentric, but some strengthening on hamstrings, and then magically they can touch your toes. All because the brain was like, oh, that's what I wanted. I wanted some pressure put on that thing.
Yeah. Okay.
And that's what it's asking for.
So I know this is one of the great things that I like about CrossFit is the group dynamic and having people there. And I like to go to the 11:30 class. It's one of the bigger classes at CrossFit Forte where I go. And of course, there's people of all different stripes and types and opinions and those types of things. And I know there's at least one guy there who, would think there is something valid to physical therapy, but he thinks chiropractic care is like, it's like, I don't know if he thinks it's a scam or what. So like, what would you say to that then? Like, why would he think And because I know there is some sentiment out there. I mean, I talked about it with Michael when he was on the podcast that some people do think chiropractic care is like a quack or kind of a scam or whatever. That there's not real science behind it.
Yeah.
So, but then apparently some people might believe that, but think there is a science behind physical therapy. So, like, what's behind all that? Do you think?
So a lot of this mindset and what people have heard from other people. They're like, "Oh, chiropractic is a quack." Oh, I mean, I can tell you. Probably, I don't know if I could tell you as many people, but I've heard a lot of people say, "Oh, physical therapy, that don't work." You know,
oh, really?
All they do is...
Oh, you hear that too?
Yeah.
With physical therapy?
All the time. Like, with the physical therapy,
kidding.
that crap didn't work. It didn't help me.
Okay.
Most of the times because they were non-compliant or they were seen with like a bunch of people at the same time.
Sure.
That stuff happens. But the truth is that manipulative therapies, which is more along the lines of what chiropractic care is, it has a lot of evidence behind it. A ton. Manipulative techniques and care, which a lot of what Michael and Cassie do over at Major Family.
Yeah.
They do a lot of that.
Yeah.
So there's a lot of research that says, no, actually this stuff does work.
Mm-hmm.
So I can't speak to the stuff that they do because I don't know.
Sure.
That's outside of my realm of knowledge. But I know they help a lot of people, and I know a lot of people that have gone. There's no way you would have a business like that and keep going.
Right.
If it doesn't actually help people.
Yeah.
It just doesn't work.
Yeah. No, most certainly. Dry needling. That's something I don't know a lot about, but recently had a friend's wife who acupuncture. I don't know much about it, but my understanding was acupuncture kind of changed her life.
Yep.
Diet and what she can eat now.
Yep.
And I mean, it was pretty crazy. Like she was telling us how this has happened, like how it's changed basically every aspect of her.
Mm-hmm.
And I'd never heard that before. I don't know any science behind that. So you say dry needling, is that a form of acupuncture, or what's the difference between acupuncture and dry needling?
Yeah, no, it's not a form of acupuncture. No, I'll go ahead and put that out there. Acupuncturists, it's kind of gray, and I don't want to speak to what they do very much because I don't know. Basically what I can speak to what dry needling is. Dry needling is basically we take an acupuncture needle. It's the same needle, okay, but we then insert it into a muscle. For the most part, it's muscle. Sometimes you'll get it close to a nerve on purpose. And the idea is that you perforate the muscle or you stimulate the muscle with electricity. And what you have is a result is you're going to have increased blood flow to the area. So it's sort of like your ISTM stuff that I talked about earlier, the tool stuff. So you're going to have increased blood flow to the area. You can also have the release of endorphins and cephalins, which are your natural painkillers. That's more along the lines of if you use low frequency electrical stimulation. If you do that, you're going to have a release of feel-good chemicals at the site of the injury or wherever you're needling. You also can facilitate muscles that aren't moving well. So I've literally taken people that could move their big toe because they had a lumbar discectomy or a lumbar herniation. They could move their big toe and stimulated that specific muscle that attaches the big toe and made it move again. And it became strong in an instant.
Mm-hmm.
So it depends on what you want to do with it. There's many, many different indications for dry needling. There are some contraindications too, like you can't be pregnant. You can't have just had a surgery within, 12 weeks of having a surgery. You can't do it within the site. 6 weeks, you can't do it with like around the area or lymphatic area. There's many different things. And then also anticoagulants, you can't really use it with that, but it is highly effective. I do it every day.
You do dry needling every day?
Every day.
What is a common injury or reason for dry needling?
So I'll do it a lot on lower back. I do it in hip, neck.
Okay.
More along like shoulders,
okay.
like upper trap and that sort of thing up there. Forearms. I've even done feet.
Okay.
Where the muscles of the feet get.
So lower back, for example, what's the reason? Someone comes in and says, man, I have lower back pain. I'm having a hard time getting rid of it.
Right.
Or is there a particular type of lower back pain that you would dry needle for?
Well, it depends on the
injury.
It depends on the assessment.
Okay.
So assessment tells you what you need to do, right?
Yep.
So if you feel around you like the muscle's tight and it's very irritated and facilitated means it's mad. Like the nervous system has said, okay, you need to tighten down and hold all you might because I'm afraid something doesn't need to move. And it's a lot of times we need to coax the body and saying, it's okay, we're going to add a little bit of movement to it. But basically what we're doing is for like, say, a person with low back pain, we'll try to feel, okay, is it muscular? Is it a problem that's muscular? Is it a problem? And 9 times out of 99 times out of 100, anytime you have like a disc problem or something like that, muscles affected too, because it's right by it.
Right.
Right? And it oftentimes catches a little bit of innervation from the segment that's affected. So if you say, for instance, like you have a multifidus muscle that connects right by the spine, and it can actually cause the spine to pinch down on one side. So if you have a disc that's bulging that way and the multifidus goes like this, you could be pushing that disc out a little bit farther and hitting the nerve even more. So oftentimes what I'll do is I'll needle the multifidus muscle, put the needle down in there, we'll stim it, get that to relax, and then all of a sudden their lumbar extension gets better. And they have more range, and then they come off the table and like, ooh, that feels a lot better.
So now when you say put the needle down in there, is there aesthetics involved, or it's just a very small needle? Like, this sounds painful.
No, it depends. Sometimes they don't feel it.
Okay.
And it depends on like how they perceive pain, if they have loss of sensation or whatever. But like for like say a low back, most of the time people are going to feel it and they're like, ooh, and it's like a quick like catch.
Like a pinch.
Yeah.
Like a pinch, or like a bee sting, or what's it feel like?
I always tell people you'll feel the tap and you'll feel pressure, and a lot of times you'll see their muscle go, and it'll like catch real quick. It's a muscle twitch. It's an involuntary muscle response. They didn't do that on purpose.
Okay.
It's because you probably hit a motor point. Motor point's just a dense area of nerves.
That might twitch when the needle's in.
Yeah.
Okay.
Yeah, it'll twitch, and if you piston, it might go boom, 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 and twitch.
By piston, you just mean gently in and out? How, when you go in and out, do you go in and out like an eighth of an inch, or do you go in and out like half of an inch? Like when you piston, how big is that piston?
Depends.
This sounds crazy, man.
If we're talking about, if you're talking about a glute, sometimes it's, about that far. It could be
3 or 4 inches.
It could be.
You'll put that needle 3 or 4 inches into a glute, and then pull it back out 3 or 4 inches, then put it back in.
Maybe not quite that far,
but 1 or 2 inches.
Yeah, could be.
Like how? Like super slow? So like so slow,
No. It's quick. When you're pistoning, it's boom, 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 boom. It's like it's pretty fast.
Man, this is crazy. So you have, what does this needle look like?
It's just acupuncture. I didn't bring it with me. It's like a fine. Think like a threader's needle. Like if you're a needle and thread, like maybe I don't know, 3/4 the size of that. It's tiny.
And does any electricity go into there?
If you hook it up, yeah.
So that's a way, but no fluids go in there.
No, it's
this
dry.
Is just
does not have a lumen.
Well, it's dry needling, I guess you just said.
Mm-hmm.
So the whole thing behind this is we're going to introduce a foreign object to the muscle to generate a response that we're going to kind of hack the body.
Yep.
If we inject a foreign object into the muscle's going to react a certain way, and that's going to be good for the problem you have. That's basically dry needling.
Yeah.
And do you like, how do you not injure the muscle from that? It's just because the needle's so small?
Well, I mean, you're creating a little micro trauma there. But the thing about it is the thing is so small and muscles are so vascular, right? You were talking about earlier, the red. They're so vascular, they heal really good. So if you perforate the muscle, now I'm not going to just like beat it into oblivion, right? We're not going to make Swiss cheese out of this thing, right? You're talking about little bitty microperforations like that are there, and there's a lot of different to regenerate stem cells in knees. Sometimes they'll do microfractures in the knee. It actually causes the body to release stem cells, which then regrow cartilage. So the little microperforations, basically what it does is it introduces blood flow to the area. Sometimes what you'll have is the release of, actually you will get macrophages, which are the cells that come in and eat up the bad tissue that's dead or needs to be remodeled and things like that. And it will help it'll say, oh, we need to be aware of this area. Oh, yeah, I forgot that was there. And so the blood will then rush to the area, and it will cause like a healing response. You get nutrients that are coming in from new blood that are there. Sometimes the area just has become, I don't want to say hypoxic, but it can become acidic. That's the word I was looking for. And based on the acidity of it, it doesn't create an optimal environment for healing. So that helps to restore pH balance. It can also reestablish the neuromuscular connection from the nerve to the muscle. The way nerves work, they release acetylcholine for muscles. They release acetylcholine at the neuromuscular junction. That's where the nerve meets the muscle. It binds it to muscle. Then you have the muscle contraction. That's how it works.
Okay.
Sometimes those nerves get leaky and they leak out acetylcholine. Then you have this not feeling thing, and it's called a trigger point. And so by perforating the muscle there or stemming it, whichever one, you can do both. It actually causes the reuptake of acetylcholine at the synapse where the nerve meets the muscle.
What's it's not a term. I'm looking for the term here. Needle is the term. Like a small, or like a tack, but not a tack. I'm thinking of like a really very small, like a sewing needle.
Yeah.
Okay. A dry needle is probably not smaller than a sewing needle, right? Because a sewing needle is very tiny.
Yeah.
But I just feel like if I would get a sewing needle and stick it in my glute, for example, that's going to hurt. Well, of course, it's probably not a good idea. This is not like, do not try this at home. But my point is, if I were to get a sewing needle and stick it in my glute, it would hurt.
Yes.
But if you dry needled it, somehow it wouldn't hurt. What's the difference?
Well, it doesn't. I'm not saying it's going to feel good.
Okay.
I had my hip done, and it did not feel good. I had very tight muscles, and it actually did kind of hurt.
Okay, where on the front?
It's actually in my glute in the back.
In the back.
Yeah.
Do you shut your eyes, or like someone sticking a needle in your body? That is.
Oh, you're face down, so you can see it anyway.
Okay.
So.
All right. So you're laying on a table, and someone's like, "Hang on, I'm going to get a dry needle. Hold on tight," and they stick this. Obviously, there's
a consent process involved.
Right. But the point is, though, they're sticking a needle in your body.
Yeah.
There's no anesthetics involved.
No, you don't need one. It's a very small needle. It's not like the big giant needles they use to stick in your veins to draw blood. It ain't like that.
So clearly, look, I'm not at risk of getting a needle and sticking in my arm for fun. There's no part of me that wants to do that. But theoretically, someone could do that, and if they knew what they were doing and they had the right needle, someone could stick a needle in the muscle on their own body at the right place, and it could benefit them.
Possibly, maybe.
So, So that explains why there's a magician named David Blaine who does all kinds of crazy stuff, and he sticks stuff through his body. Like he sticks stuff through.
Oh, I know who you're talking about. Yeah.
You know who I mean? Is that the same process? Because he mentioned something. It's not the same process, but he mentioned something about. Like when he has stuck something through his, I think it was straight through his stomach or something. It was crazy. And he just mentioned if you do this, you have to do it slowly, and the body sort of, I guess, receives it decently. But if you do it quick, like that's going to be a problem. So when you're sticking a needle in the body, it's just I'm just picturing like you got to kind of poke through the outer layer.
Yep.
And once you have poked through that, it's like, just like
it slides
butter
through.
on like warm, like a knife on warm butter.
Yeah, it normally just slides right onto the muscle. Pretty
oh man,
yeah,
man, that's. I'd love to I sort of like to experience it, but I'd be like super scared.
I should have.
It's a fascinating. Yeah, that's. I've never. I don't know much about it. It just seems crazy. It seems like an abuse of the human body. You also had some, I think this was when we were texting or something. Did you have some thoughts on how MRIs happen and how they have to happen? The process is always you're laying on your back, and that can be a negative. I think you had some thoughts around that I wanted to ask you about.
So I don't mean to be time sensitive, but I have my last client of the day I have to run to. But
how much time you got? We got to get you out of here?
Yeah, I do, but I'll answer this question though. So basically MRI is a still image of time, right? It basically captures you laying on your back in probably one of the most comfortable positions most people have with back pain or even sciatica. They prop the legs up, they lay them down, and they stick them in the tube. Right. And the problem with that is it's nothing's loaded, right? When do most people with sciatica and low back pain and everything hurt? Is it when they're laying down? Or is it when they're standing up and walking?
See. Yep.
And that's my question. And it's not to say that they're wrong, because obviously there probably could be something there. Well, research shows us 50% of people my age and older are probably going to have something like a disc or something in their neck or their back or their knee or something like that. But they're asymptomatic and they don't actually have pain.
Yeah.
So,
yep.
It's not necessarily, I always tell people you're not your MRI. And if we look at people differently and more from a systems approach, we can understand that better and we can treat them better.
That makes sense. So we got to get you out of here. What is, though, your advice to the everyday person as it relates to health and form and function and fitness and that type of thing? Like, there's some common mistakes or just some good advice you leave people with?
Really, I would tell you to focus on how you move. How you move first, and that's what I'm doing with this lady. Actually, the lady I'm about to go work with, we're working on getting the biomechanics right first. Then from there, build that's your foundation. Then build off that foundation. Biomechanics absolutely first. Don't try to lift heavy first. Get your biomechanics right. Start getting the biomechanics right. Then you will naturally start building strength in the right ways.
Yep. Cool. Makes sense. Doc, thanks for coming by.
Yes, sir.
Really appreciate it. It was fun.
Yeah,
Thank you.